Okay, so this is a module on breast implants. Starting out with a quick this versus that. So we've got two different mammograms here, both of which have breast implants, but they're different. So which one is which? Just point out a few things here. On the red one here, notice that you can see through this one, sort of, as opposed to the yellow one here, which you can't. It's like a total whiteout. So that's how you tell the difference between a saline implant and a silicone implant. So this is the general scheme of things. There's basically two main types of breast implants. You can have saline or silicone, and then they can be subglandular or subpectoral in location. Both of which can rupture. So here would be the algorithm, and this would make a good next step kind of question. Patient has saline implants. They could even do a link type question by first showing you that the patient has a saline implant and making you figure it out by being able to see that you can see through it. And then they could say, well, they're suspecting rupture. What do you do? So it depends on what your choices are. The wrong answer is MRI, and the wrong answer would be ultrasound. The wrong answer would be PET or nuclear medicine or anything like that. Correct answers would include physical exam or a mammogram. If they put both of them on there, I think I would start with physical exam because it should be obvious if it's deflated. But if they want you to choose an imaging modality, you would definitely start with a mammogram. The reason is that silicone implants will form a capsule and saline implants won't. So there's no such thing as intracapsular saline rupture. It's not a thing. In addition to that, no one really gives a shit if saline implants rupture. I mean, it doesn't really matter other than cosmetically. Basically, if it's ruptured, you go see your family medicine doctor or your surgeon or whatever. Like, it doesn't require any kind of additional workup. The silicone ones are more complicated, and even though you can start with a mammogram, and if it's a gross extracapsular rupture, it'll be obvious. You have like silicone splattered all over the place, and it'll be clear asymmetry. But you may need, if you want to start cheap, you could go ultrasound first, but the definitive exam is going to be MRI to be able to tell. So this is a good look for a ruptured saline implant. I know it's a saline implant because I can see through it. I know it's ruptured because it's obvious that it's ruptured. It's not an eye test, gross asymmetry, and you can sort of see this one here is sort of folded up like a plastic wrapper. Again, it doesn't really matter. Okay, so this versus that. So we've got squiggly looking things inside of a boob or boobs, bilateral boobs that are slightly different squigglies. Now the first thing, and I've mentioned this in numerous other modules, is to describe the sequence. Now, breast MR, which we talked about in the last lecture, has specific sequences to look at the breast tissue. Fat saturation is a really important thing. For MR of the implants, there's a special sequence that's done, which is a T2 fat saturated sequence, where basically everything is nulled out except for the silicone. And that's the only thing that you wanna be able to see. All right, so let's look at these again. I'm gonna go through each one and explain it. So this is an implant before it's put inside of somebody, and I just want to point out that there are these areas of infolding And if you would look at this in cross-section, it would look something like that. And then here's our case. This was our red case. And this is what's called a radial fold. And the reason it matters is because it's a mimic for intracapsular rupture for people that haven't looked at a lot of breast MR for implant rupture. It's the most common trickery with regard to trying to get you to say that there's intracapsular rupture. But it's not. And you could probably imagine that this other one in orange is intracapsular rupture. So what does that mean, intracapsular rupture? So here's a boob, and we'll put an implant in it, make it a little bigger. So this does not happen with saline implants. This is a silicone implant thing. The body it's a foreign body, right? So you're going to wall it off just like you would any other foreign body that was present. So your body forms a capsule around it. And that's what they mean when people say there's intracapsular or extracapsular rupture. They're not talking about the envelope of the actual implant. They're talking about this capsule that your body makes. So if you've got breast implants and you slip and fall on ice, land on your boob, you've got some kind of trauma, you can have a tear here of the envelope of the implant, but you still have maintained integrity of the actual capsule. Remember, the capsule is that thing that your body made, the red thing. In this case, you've got intracapsular rupture. Silicone is still confined inside the capsule, but the envelope is ruptured. So you've got silicone oozing out, but it's not like a gross perforation. And these things sort of look like, well, the buzzword is going to be like a linguine, like a piece of linguine, like this guy. Sometimes you'll see it where it's floating full on like that. I've got a case of that I'll show later. Notice that this piece here is not attached to the wall. That's a big difference between that and radial folds. Radial folds, everything is sort of attached. This thing, you can see you can imagine that there's a tear here, like right there. Like it's intact here, and then there's a hole there. And that makes up about 80% of cases. So this is the majority of implant rupture is isolated intracapsular rupture. So here's scenario 2. You've had an injury that violates both the envelope of the implant as well as the fibrous capsule. And this is what they'll call extracapsular rupture. But I want to point out that if you have extracapsular rupture, you've also ruptured the envelope of the implant because there's no other way to get silicone out. So you've got, here's your linguine sign, here's your intracapsular rupture, and then you also have silicone outside of the envelope, so that's your extracapsular rupture. So you've got both, and this is the 20%. So 80% isolated intracapsular, 20% intra and extra. So can you have isolated extracapsular rupture? No intracapsular, just extracapsular. Is that a thing? In other words, can you have silicone here, but not there? No, you can't, right? That's not possible. So this is another thing that's, because it's confusing, makes a good question. You can have isolated intracapsular, like I said, just the envelope is torn, but it's inside that fibrous cup. And you can have intracapsular and extracapsular, but you can't have extracapsular by itself. So just a rapid review here. This is a radial fold. This is your linguine sign of your intracapsular rupture, and this is both. Notice that there's clear connection here all the way to the wall, and there aren't any Nothing sort of looks like that, where you've got like a folded up part with silicone on both sides. Nothing looks like that. All right, so here's an ultrasound case. This is an Aunt Minnie. This is the so-called snowstorm appearance. I actually think this looks like a snowstorm. It's like pretty accurately described. And what we're talking about is this sort of gray stuff here. All of this mess. And that's what silicone looks like on ultrasound. So this would be an extracapsular rupture. So this person has had a history of implants, and we notice that they've got these high-density lymph nodes. So if you were presented with a next step question here, you would have to say ultrasound, and then you ultrasound these high-density lymph nodes, and it looks just like the last case. It's a snowstorm appearance inside of a lymph node. And this is the silicone adenopathy. If you see this, they want you probably to, in the setting if the patient still had implants, this person doesn't have them anymore, but let's say they had implants and they were suspecting rupture, they've had a trauma, and you note that, the next step would be to get an MRI to look for an intracapsular rupture because you may be leaking a small amount of silicone. But it doesn't mean for sure that you have had a rupture because there's this entity called gel bleed, which basically is the normal transudation of microscopic amounts of silicone through the intact shell. A lot of those like squishy children toys are made of silicone. They get really gross when they're like hanging out on the floor. They get like dog hair and stuck to them. If you ever pick one of those up, your hands feel a little sticky sometimes afterwards. That's gel bleed, and the same thing is going on there. But the take-home point is silicone outside of the implant on ultrasound has this very classic snowstorm appearance. Nothing else really looks like that. So here's some quick rapid review on implants, some testable stuff that I think is testable trivia. First, implants are not a contraindication for core-needle biopsy. You can still biopsy the breast even if they have implants. You just have to pay attention to what the hell you're doing. Yes, you can puncture an implant with a biopsy needle. Even with an F&A needle, you could potentially deflate a saline implant if you're an idiot and you don't know what you're doing. But it's not a contraindication. There is not an increased risk of breast cancer with implants. This was a thing that people thought in the 80s or whatever. It's never been proven. Implants do not increase the risk for cancer. They do, however, make it more difficult to screen. So when you do screening mammography in the setting of implants, you get 4 different views. You get your standard CC view and your standard MLO view. But in addition to that, you get a displaced CC view and a displaced MLO view, and that's something the tech has to do where they try to push the implant out of the way and just image the breast tissue. So I mentioned at the very beginning of the talk that there are subglandular implants and there are subpectoral implants. Now, the benefit of subglandular implant is that supposedly feels more natural. Supposedly. The subpectoral implant, the advantage to that is that it's easier to displace, and so when you do a mammogram, you've got, if you're going to choose which one you want, and you're choosing it based on which one's easier for screening, you would choose a subpectoral implant. If you were choosing it just based on cosmetic feel, you would pick subglandular implant. And that's it. It's the end of the breast series. That's the end of this talk. The next talk will be headed into our nuclear medicine series. You probably have noticed that a lot of the nuclear talks have been scattered sort of throughout the rest of the modules, but I do have a few that are dedicated nuclear talks, and that will be headed now.